You reach for the upper shelf and arch backward, not bending, not lifting, arching and twisting. The pain sits in a band across your low back and does not run down your leg. Worse the longer you stand, worse straightening out of a chair, worse walking downhill where your spine holds extension the whole way. That pattern raises suspicion. It does not make the diagnosis, and I will show you why. And someone handed you a report reading multi-level facet arthropathy, degenerative changes, then injected you twice on the strength of it. I am an interventional pain physician, and this is what I want you to know. Nobody read that report to you carefully, so I will. It describes what your joints look like at your age, not that they produce your pain. Facet arthrosis turns up on a large share of scans with age and correlates poorly with who actually hurts. No scan finds this diagnosis, no exam maneuver either, not extension rotation, not paraspinal tenderness, not a thumb on your back. A clinic that schedules 3 facet injections before interpreting the first is not diagnosing. It is billing a hypothesis. The zygapophyseal joints, the facets, are true synovial joints. Cartilage on paired surfaces, a synovial membrane, a fluid-filled space, a richly innervated capsule. Cartilage thins, the capsule stiffens, the synovium inflames, the joint hurts under load. Extension and rotation do it. Arching closes those surfaces. Rotation shears them. That is your pain pattern. Now the part that governs everything. Each lumbar facet joint carries 2 nerves, medial branches of the dorsal rami, one from the level above, one from its own level, crossing where the superior articular process meets the transverse process under the mamillo-accessory ligament. One exception at the bottom. The L5-S1 joint still takes 2 nerves, but the lower is not a medial branch. It is the L5 dorsal ramus itself, at the sacral ala and S1 superior articular process junction, paired with the L4 medial branch above. 2 targets still, one differently named and sitting somewhere else. Miss that and the block is meaningless. Anesthetize one, learn nothing, silence both. Now, the number that should have been on the consent form you signed before that first injection. Manchikanti and colleagues in Pain Physician 2020 studied chronic low back pain with controlled comparative lumbar medial branch blocks under fluoroscopy. About 34% proved facet-mediated, and a single block, 1 injection, 1 report of relief was falsely positive close to half the time, 50% a coin. So we do not accept a single positive block. Controlled comparative blocks, short-acting anesthetic first, longer-acting second, 80% relief, or better on both, duration matching the drug's pharmacology. I would rather correctly exclude you than wrongly ablate your nerves. Understand what a diagnostic block is not. In that same study, relief at the 80% level averaged 6 days with lidocaine, 13 with bupivacaine. Partial relief, 50% or better, ran longer, about 32 days and 55. Weeks, not years, and then it is gone. A medial branch block is a question, not a treatment. Sell it as therapy and you are selling a lab test as care. Those numbers are lumbar. Cervical facet pain is real and the logic holds, but I will not stretch low back figures onto a neck. So how do you interrogate a joint no scan can convict? You anesthetize its nerves one at a time, under conditions strict enough that the answer means something. Here is how we set them. We favor the medial branch block. The 2020 multi-specialty consensus guidelines from Cohen and colleagues in regional anesthesia and pain medicine found medial branch blocks more predictive than intra-articular injection for selecting patients. A block tests the nerve radiofrequency will treat. Be clear what the other procedure is, because it is what most people are sold. An intra-articular facet injection drives the needle through the joint capsule itself into a space holding barely 1 to 2 milliliters before it tears and deposits steroid inside the joint. Different target, different path, different question. That treats a joint. A block interrogates a nerve. For diagnosis, we interrogate the nerve. The diagnostic block contains local anesthetic only. No steroid. Days later, you could not separate an anesthetic response from an anti-inflammatory one. And no corticosteroid carries an FDA-approved indication for spinal facet or medial branch injection. That is off-label. Volume stays a fraction of a milliliter per nerve. More spreads to structures we are not testing, and manufactures a false positive. Live contrast first, excluding intravascular uptake, which produces a false negative. You leave with a pain diary and instructions to provoke the movement that hurts inside the anesthetic window. Your honesty, then, is the instrument. Now, who a medial branch block actually helps and who it does not. Candidates have axial low back or neck pain beyond 3 months, worse with extension and rotation, without radicular pain, weakness, numbness, or neurologic deficit after failed conservative care. New weakness, bowel or bladder change, fever, weight loss, active infection, or uncontrolled bleeding risk means urgent evaluation, not an injection. The differential, discogenic pain, sacroiliac joint pain, hip osteoarthritis referring to buttock and groin, spinal stenosis, myofascial pain. MRI does not separate them. Pattern, exam, and selective blocks do. What a needle placed next to a medial branch can do to you. Soreness or a pain flare for 1 to 3 days. Bruising, a vasovagal faint. If a corticosteroid is used, and in a purely diagnostic block it is not, expect several days of elevated blood glucose, which matters if you are diabetic, plus facial flushing, insomnia, fluid retention, and temporary adrenal suppression. Repeated steroid exposure can affect bone density. One more reason our diagnostic block contains no steroid. Temporary numbness or weakness in a limb if anesthetic spreads. Do not drive until it resolves. Uncommonly, infection including septic arthritis, bleeding including epidural hematoma. That risk rises sharply on a blood thinner. So tell us every anticoagulant and antiplatelet you take before we schedule. Dural puncture with spinal headache, intravascular injection, allergic reaction, nerve injury. In the neck, temporary unsteadiness and scalp numbness after a third occipital nerve block. Arrange a ride home. Those nerves sit near the vertebral artery. Injection into that vessel, or rarely spinal cord injury, are recognized risks there. Live imaging with contrast is not optional. Fluoroscopy uses ionizing radiation. Tell us if you may be pregnant. A positive result buys candidacy for radiofrequency neurotomy of those nerves. The Cohen guideline says it may benefit well-selected individuals and attaches no duration. Observational series suggests 6 to 12 months. Nerves regenerate. Pain can return. Biology, not failure. And what the evidence does not support. Kennedy and colleagues in the American Journal of Physical Medicine and Rehabilitation in 2018 randomized dual-block confirmed Facet patients to triamcinolone or saline inside the joint. The steroid did not reduce or delay the need for radiofrequency neurotomy. 28 subjects, endpoint a procedure rather than a pain score, that does not prove steroid useless, but nobody can honestly promise months of relief from steroid inside a facet joint. Nutrition, pro-resolving mediators, and red light therapy are adjunctive or emerging here, not established care. What I'm about to describe is a composite, a picture assembled from many patients with this condition, not one person's chart. 3 years of band-like low back pain, worst standing at a counter, worst arching to a shelf, never below the knee, 2 intra-articular injections elsewhere, neither explained. First, medial branch block, lidocaine, bilateral, 2 levels, 4 nerves, 90% relief that held about a week, then faded back. That fading was the hardest part. It felt like failure. It was an answer. The second block, separate day, longer acting agent, reproduced the same 90% us and held roughly twice as long. Exactly what that drug should do. 2 matching answers, the second outlasting the first. That earns radiofrequency. The neurotomy was slower than anyone wants. Sore 2 weeks. Relief did not consolidate until the third. Then months of function, alongside rebuilding mechanics that guarding had degraded. Late in the first year, pain returned as the nerves regenerated as we said it might. And the other outcome, equally a success. Same story, same MRI language. Second block negative. We stopped. No ablation. We looked elsewhere and found the real generator. Treating the wrong structure is the failure, refusing is not. If your pain is worse when you arch and twist, bring your imaging and history to us. Padda Institute Center for Interventional Pain Management. We are at 4477 Woodson Road, Suite 100 in St. Louis, Missouri. right next to St. Louis Lambert International Airport, and at 12174 Natural Bridge Road in Bridgeton. We serve the St. Louis region, Missouri, and Illinois. Call 314-481-5000 or text 314-886-5902, Monday through Friday, 8 in the morning to 5 in the afternoon. The full explanation is at painmd.tv under Pain Treatments Facet Joint Injection. Demand the diagnosis before the procedure. That changes what medicine is allowed to do to you. If something in this changed how you understand your own pain, that was the point. Bring us your imaging, your history, and your questions. Padda Institute Center for Interventional Pain Management. We are at 4477 Woodson Road, Suite 100 in St. Louis, Missouri, right next to St. Louis Lambert International Airport, and at 12174 Natural Bridge Road in Bridgeton. We serve the St. Louis region, Missouri, and Illinois. Call 314-481-5000 or text 314-886-5902, Monday through Friday, 8 in the morning to 5 in the afternoon. Everything in this video is education, not medical advice. Ask for the diagnosis before you accept the procedure.